Today, I'm really excited. We're joined by Dr. Mike Woodruff. He's a seasoned emergency medicine physician and healthcare leader who currently serves as the senior medical advisor for Fidelum Health. Mike was the former chief patient experience officer at Intermountain Health and has over 15 years of experience leading teams in human-centered, data-driven approaches to reducing patient harm and creating better patient experiences. Thank you, Mike, for being here. Susan Edgman-Levitan will facilitate today's conversation. Susan is the executive director of the John D. Stockel Center for Primary Care Innovation at Mass General Hospital, and she serves on numerous boards and committees, including the ABIM Foundation's Board of Trustees. Thank you again for joining us for what I know will be a great conversation, and I will turn it over to Susan.
Thank you, Jessica, and welcome, Dr. Woodruff. To get started, Mike, can you share a little with us about your background and how you got interested in this work?
Sure, I'd love to, Susan. But first, let me just say that it's a total honor to be here with you, with the ABIM Foundation, and with everyone in the audience. Susan, your background and your work and what drives quality outcomes, trust, and experience is just phenomenally impressive. And I'm really looking forward to learning from you as we go.
Thank you, but today you're the star. So,
with that said, I really went into healthcare to devote my career to helping people, to alleviate unnecessary suffering. And really early on in my experiences, I learned that there were so many opportunities to improve, particularly communication and psychological safety in healthcare. And can I tell you a quick story?
Sure.
When I was just thinking about going to medical school, I got the opportunity to spend 3 days and 3 nights in a trauma hospital, an urban trauma hospital, and got to shadow the residents. And before I got turned loose in the hospital, the head of surgery grabbed me by the shoulder and said, "Mike, there is such a thing as a stupid question. Now don't ask any." And what I heard from that was, keep your mouth shut, don't touch anything, and just watch and listen. And after about 24 hours, it was early in the morning, we were in an emergency surgery from a gunshot wound, and I was standing in the operating room next to a piece of equipment that I now know is called a cell saver, which is essentially a pump that takes excess blood from the operative field and recycles it and filters it and puts it into bags so that the red blood cells can be retransfused into the patient. And I didn't know much about it, but I did know that something was wrong with the machine because I saw that there was a kink in the tube, and I heard a high-pitched whining noise that was building in volume as the surgery went on. And because of what I had been told, I was very nervous to speak up. And what ended up happening was, with a loud pop, the tubing popped off of the machine, and that tube sprayed blood all over me and all over the ceiling and all over everyone in the OR. And that told me pretty early on that there was such a thing as creating the wrong set of expectations around how people behave in a healthcare environment. I spent the next 6 months worrying whether I had hepatitis or other bloodborne infections, and boy, it was just a formative experience for me. And I just saw the doors open to what needed to happen in healthcare in terms of safety, communication, and particular psychological safety. I became an emergency physician because I love solving problems acutely for people, helping them through really hard times in their life. And in my work in the emergency department, I was really fortunate to have mentors that told me that my responsibility was to continually improve medicine. Not just the care that I was providing, but to improve medicine and train the next generation to become better clinicians. And the more I got into the improvement work, the more I saw that the people that were suffering were not just the patients, but they were also my colleagues. And they were suffering from kind of compassion fatigue. They were cognitively overloaded. Some of them were burned out. And I saw that that was a burden that really needed to be addressed in healthcare. And so I think in my improvement work and my improvement career, 2 things really caught my attention. One is that if we're going to improve and sustain the improvements, we need to make it easier to do the work and easier to do the right thing. If evidence-based care is built into the system that you're operating in, it's so much easier. It's hard to choose to do the wrong things. And you only do it when you have a really good reason to deviate. So what I found is that if you design really good workflows to include evidence-based care, excellence scales and sustains much more easily. And then secondly, I think connecting with compassion to the challenge of working in healthcare really hit home for me. I mean, if you just think about forgetting for a second all the administrative burden that's on our clinicians today, if you just think about the intensity of the emotional interactions, the interpersonal interactions that they're having, sometimes life and death, sometimes life altering, that alone is a heavy burden for our clinicians to bear. And we don't often talk about that.
Yeah.
I think you and I will talk about that a little more later. I think in my work at Intermountain, leading quality and patient safety and patient experience, I really understood the importance of culture and of teams and of workforce engagement in getting results.
Yeah. Well, I think your story about the cell saver, I think we probably all of us who've been involved in clinical work have had some sort of experience like that, that if we're lucky was transformative and changed the way we interacted with others going forward. Can you say a little bit about what person-centered care means to you, and how have you ensured it remained a priority in organizations you've worked with? Because many of us are concerned about what seems to be, it's not a movement, but it seems to be that many patient experience leaders are either leaving or getting moved into different positions, which is quite worrisome to me.
Yeah, I agree. I agree that trend is alarming, but I do have some hope there. First, I'd say there's a lot of different definitions, and I'm glad that you asked me what it means to me, because I think it means something different to almost anyone you talk to. When I go back to why do we need a term for patient or person-centered care? If healthcare were automatically, magically, somehow fulfilling all the needs of the people involved, we would need to talk about this. And in fact, we have actually been discussing this for decades. The concept first arose actually in the 1940s to 1950s. And have we totally delivered on it? I would suggest no. We're still harming people to the tune of tens of thousands a year. We're still sending people pieces of paper from their insurance that say, this is not a bill. What is it? I have no idea. Just to confuse you. It's a confusion letter. And I got an email the other day for a pre-procedure. There was a pre-procedure form that I had to fill out that asked me this question: do you have an email address? So in terms of patient centricity and knowing, or persons and knowing who I am, I don't think we're totally firing on all cylinders quite yet. To me, really, the term means a holistic view of the person that's in front of you, and what are all the pieces of their life, of their lived history, that's going to impact the therapeutic relationship that I build with that person, so that ultimately they're willing to trust me and, follow my recommendations for health. And I think the other key part here, and maybe the remedy to what you're seeing with patient experience leaders, is that I don't think you can have this conversation about person-centered care without talking about clinicians.
Oh,
because they are part of the care, and they are people, and they are impacted by it. And what they bring to the table is really important for them to deliver and execute kind of on a routine basis at the highest level possible.
yeah. I mean, one of the things that concerns me is that having been very involved in developing the more recent concepts of patient and family-centered care, many times that gets interpreted as we just need to have a piano in the lobby and valet parking and a menu people can order from. And people really underestimate that when you talk to patients about what matters to them, all you hear about are the clinical issues that all of our clinicians care deeply about. And so it really is about improving the way we're providing clinical care and supporting our patients to manage their own conditions or whatever health issue they're faced with. I still think about a person that was very influential in my life, Harvey Picker, who funded a lot of our original work in this area because of horrible experiences that he and his family had. He described the American health system as a system that either viewed patients as inventory or imbeciles. And I think that we have moved a long way from that, but we still have a long way to go to engender trust. So tell me a little bit about...
Susan, could I just... I don't think I finished the answer to your question.
Go ahead.
Which was, how do you keep the organization focused on person-centered care? And the one thing I'd like to add is that I really think as leaders, we need to have the ability to bring the conversation, when appropriate, which is almost always, back to the why of what we're doing, caring for patients. And if you bring it back to that, it becomes clearer the right path often, even in some very difficult conversations. And I think you've probably heard, and everyone on this call has probably heard the term no margin, no mission.
Yeah.
It's easily used to put kind of financial concerns ahead. I would say no team, no mission. No patient, no mission. No doctor, no mission. No clinician, no mission. So we've got to be able to tell the story that brings it back to the fact that healthcare can run on low margins. It can. Healthcare organizations can lose money and they can still provide care. It's happened. But they cannot lose their teams and keep providing care. They can't lose their patients and keep providing care. Wow. So bringing it back to that why is a really crucial skill to have as a leader.
Can you say something? I think that what you just said is really, really critical. And I'd like you to touch a little bit on the link between the healthcare team member safety and well-being and the overall patient experience. How are those things connected?
Well, in my mind, and I'd love to hear your thoughts on this, in my mind, it goes back to the concept of high reliability. If you want to deliver this kind of safe, effective care every single time, and every single time we do what we intend to do, and that extends to providing a great experience for the patient, that means that our people have to have a consistent and trusting relationship with the healthcare organization. And they have to feel psychologically safe to speak up for their own safety. They have to feel that they have agency, that they have meaning in their job, that they have purpose at work, and that they can make choices to improve the patient's outcome. And to do that, to create that culture, it's been shown many times that psychological safety is essentially the foundation of that. Am I willing to take a risk? Do I feel that the organizational or the group will support me to take a risk in this work to do what's right? And to me, that's the core of both patient and our care team safety, is creating that open environment where we're talking freely, we're reporting concerns, and that we are free to speak up and say, what would make my job easier? Let's make it happen. And we know that results in better outcomes. And we know that, at least in my experience, and I think we have data to show this, but patient experience tracks along with those other outcomes, quality outcomes, safety, and team engagement outcomes.
It does. And I will share that over the years, as part of the CAPS research that I've been involved in, when we have gone out and done case studies or visited very high-performing hospitals from the perspective of their patients, there are a few common things they all demonstrate or do. And the number one thing that we see, every single one of them, whether it's a hospital, a practice, a nursing home, you name it, they're all great places to work. Because if you're not taking care of the people delivering care, and that's everyone on the care team, they can't take care of the patients. And I loved what you said about making it easy to do the right thing. I think about that a lot when I hear about well-being efforts and, enhancing resilience. And I don't want to ever hear about yoga again. Let's focus on streamlining the workflows and being able to do the job easily and well that we came into healthcare to do. And one other just quick thing I'll share is that there is a patient safety culture survey called the Survey of Patient Safety. And when you look at the results from that, and many organizations across the country use this survey annually in inpatient and ambulatory settings, and now even in nursing homes. And what we see is that the organizations are even down to the level of an inpatient unit or a practice that do well from the perspective of their patients have very good patient experience questions. So say a little bit about, in your experience, about things that you've learned that can really enhance psychological safety. You've said a little bit about things that don't enhance it, like don't ask questions and don't bring up any issues you see. But can you say a little bit about what you've seen and what you've done to increase psychological safety?
I'd say there's a couple traits of leaders that really boost psychological safety, and this has been shown not just in my experience but widely, that having curiosity about why things aren't working as intended rather than reacting, but asking why, and really getting to the root cause why things are not working as intended, and then being vulnerable as a leader to understand your role and your responsibilities, and how maybe you're not living up to kind of the intended standards or the intended performance, and being vulnerable about understanding that every human makes mistakes. That's a human trait. And so helping as a leader design systems that take that into account is called human factors design, right? We acknowledge that humans are going to make mistakes. So how do we error-proof the system, and how do we take into account the sometimes bad decisions that humans are going to make? And how do we create an environment that if those do happen, if we do have an unintended outcome, we come to the discussion not with just jumping in and learning, but with an attitude of caring for the team. We created a system. We found early on in our safety work that we were actually, some of our work to be really aggressive about unintended patient safety events was having an adverse impact on our teams. And the reason was, we're really good at quality improvement. Humans are. Healthcare providers in particular are really good at rushing in and saying, what happened here? How do we make it safe? How do we learn? That's the easy part. What's the hard part is that when there's an unintended outcome in a clinical setting, or even, let's say, a finance setting, same rules apply. When there's an unintended outcome, people feel bad about it, and they question themselves. And sometimes, I mean, heaven forbid, this has happened, operating on the wrong limb, that's happened. You know what the surgeon feels after that happens? Do you know what the scrub tech feels after that happens? They feel like quitting their jobs.
Yeah.
And so what we did is we understood that if we were going to get trust and buy-in into our process of learning, we actually needed to come first with caring. And so we created at Intermountain this concept of caring and learning. And the order of those words are really important. Caring first, then learning. And so we scripted it, because, you know, just asking people to do something is not enough. You have to script it. You have to make it like routine. You have to build it into your forms and your workflows and your PowerPoints. But the first step was to ask these questions. What does the team need? What does the patient need? What does the family need? That was, and until those questions are answered, you don't do anything, because the team needs to be supported, because they've got to go do their next thing.
Yeah.
Most of the time. And you're going to ask them to do the same thing next week, even if you give them a few days off, which we did when they were under stress. But that really helped kind of the audio match the video in creating safety culture. It showed people that we cared about them, and that they were our first concern, because we addressed them first. And that opened the door to a lot of valuable and powerful learning that brought people in, built trust with the idea of a high reliability culture.
Can you say a little bit more? Those are wonderful examples. But can you say a little bit more? I worry a lot that in the wake of the command and control management structures that most of our organizations went to with good reason during the worst of the pandemic, but many are still kind of stuck there. And it's affecting, I think, the way that our people feel like they have agency and whatever. But can you say a little bit more about what it actually means for a leader to show that they're vulnerable? What does that look like in practice?
Well, it's a great question, and I wish I knew all the answers to that. But and there are whole books written on that. But I will tell you that if you look, for example, at the U.S. military, at Special Forces teams, one of the principles that they follow for high performance under stressful situations is decentralized command. And that means that you, Susan, as part of my team, you have the agency to make the right decisions in the moment that are going to keep us on mission.
Mm-hmm.
And that is agency. Mm-hmm. It's informed by, a lot of training and a lot of thought and a lot of, what's the right way to act in these situations. But we have to give agency to our people to make the right choices, because a leader can't be there to tell people what to do all the time. And so I have to trust as a leader that my teams are capable, and I have to encourage that capability in them, and I have to trust them and let them fly. And sometimes that means they have to make mistakes.
Mm-hmm.
And so I have to actually encourage making mistakes
and
be okay with it. And then handle that with an attitude of curiosity and support rather than, judgment. That's a hard thing to learn. I'd say the other reason that's important, Susan, is that one of the engines of innovation for any healthcare organization of any size, one of the engines of innovation is the frontline workers.
Oh, yeah.
That are out there solving problems, coming up with better ways to do things. And if they're not thinking and not fully engaged in their job and don't feel like they have the agency to say, we're going to try this way, or we're going to think creatively about solving this problem, innovation largely dies, because innovation doesn't happen to the top, in my mind. Innovation happens by the people who are providing care.
Yeah.
And it's hugely important.
Yeah. Well, given that our program today is about building trust, I'm going to shift gears just a little bit. But can you say more about your experience with how organizations build or lose trust?
So that's a great question. It's very central. I'd say that the key first step is to realize that sustained excellence depends on the trust of engaged teams that are focused on the mission. Healthy engaged teams. So I'll say that one more time. Sustained excellence depends on the trust of healthy engaged teams that are focused on the mission. And the corollary to that is that if systems in which these teams operate, if they're not designed to build trust, they're going to lose trust, and they're going to erode trust and hurt the mission. And that acknowledges that trust is not something that once you build it, it stays forever. It's actually really hard to build. It's strong, but it also goes away very easily. It's lost very easily. And one way I like to look at this is, what are the trust killers that are hidden in your organization? I think we tend to think of what builds trust, but what are the little trust killers that are hidden in your processes that are telling people every day that the organization doesn't care about them? And I'm talking as small as a rude little email that they get once a quarter because they're overdue on something. If you don't like it, you like it or not, the sum total of all those little emails and all those boxes that people have to check and all the processes they have to fill for timesheets and check-ins and all that is the system in which your workforce operates. And you have to understand that if most of those things are either indifferent or they're annoying or sometimes downright rude, that's going to actually harm your relationship with your workforce. And so in my mind, figuring out where those trust killers come is very important. Understanding that trust is fragile and that needs active work and design to build. I have a number of questions that I ask. I call it not human factors design, but humane factors design. So number one, if you're looking at a process or a system, or an initiative, number one, does this make it easier to do my work?
Yeah.
Does it make it easier to do the right thing? Number two, does it align with the mission? In other words, does it get the outcomes that we agree upon are mutually shared, good outcomes to work on? Number three, does it make people feel better about their jobs? And that's one we often overlook, is how does this make people feel that interact with this system or process? And number four is, again, where are those hidden trust killers in the process?
Yeah.
And one more thing, IHI has a great framework. They did a great study on how to build trust in an organization, and I encourage everyone to download that because it's got some great graphics and really solid content there.
Yeah. We've got a great comment in the chat about that really resonates with me about how do we take care of people that we're seeing that may be very upset with us because of things that have happened completely out of our control or with other clinicians or staff. And how do we rebuild trust with them? And which I think is really critical. And one of the things that, the ABIM Foundation is funding research that IHI is leading, identifying what are the things that build trust with communities and with our clinicians. And one challenge has been that things may have happened at some point in an organization's life or history that have lost trust with the physicians, the other staff, or the communities. And the leaders are often in a position where they sort of don't really feel like, why am I apologizing for something I didn't do?
Mm-hmm.
But nevertheless, it's very important to acknowledge that. Can you just say a little bit about your perspective on that and some of the things that we've learned in the patient safety movement that may be helpful there?
Yeah, I mean, nothing beats the power of truly vulnerable apology. And a lot of times that's all people are looking for. I would argue that they're looking for apology, understanding, and action. So 3 things. But the biggest part to open that door is often just a straight up apology with not a lot of strings attached. And we've learned that in our early communication and resolution work across the country, that when something goes wrong clinically and there's an unintended outcome, we know that there are tangible benefits for patients, for families, for staff, for the organization in terms of financial loss if we just go ahead and say, look, we're sorry.
Mm-hmm.
And what can we do? What action can we take to make it right?
Mm-hmm.
And so, for me, it's that vulnerability on a leader level, on a human level, and on an organizational level to say, yes, this happened. We're sorry. And then secondly, I think the other key follow-up for that is listening. And not just listening a little bit. And this is where I think the IHI work is so great, is it goes deep into the fact that if you've lost trust, a little bit of listening is not going to do it, because no one's going to tell you what they're actually thinking until you've spent the time with them to really listen deeply, maybe multiple times to understand what they need, and then get an action plan together that you co-create with the person or the group. And so for me, it's those 3 things: vulnerability to apologize, deep listening, and then co-creation of an action plan that actually gets done.
Yeah. And I think at least in my own experience working on patient safety efforts, that action plan is what many people are really looking for. I want to make sure that this is never going to happen to anyone else and that you are going to take this seriously and fix it, which I think is very important. So I'm going to shift gears again. And, in our discussions before today, we both shared some of our own experiences with losing trust, regaining trust in our own, either our training or with our own clinical care. So I'm going to ask you if you might share a little bit about the experience you talked with me about when you were a resident.
Yeah, I mean, I remember telling you about that. It's early in my training, I was part of a team that was involved in the unanticipated death of a child. And I can't think of anything more heartbreaking as a clinician to think about than, unintended outcomes for a small child. And what I think I explained to you is that the sum total of discussion about that after it happened was 2 questions that got asked once, in an offhand sort of way about what happened. And as far as further conversation, there really wasn't any. And the result of that for me, and again, I was in an early stage of my training, so I was fairly impressionable, but not that I'm not impressionable today. But, the impact of that on me was I carried that around as a burden for probably most of my career because it hadn't been talked about. And it makes me wonder how many of our colleagues are walking around with undiagnosed PTSD and trauma that needs to be treated. I think, Susan, one of the exciting things is these days we're not in the dark about trauma anymore. And I think I saw a comment come across about trauma-informed care. We know there are really effective modalities for treating trauma and traumatic experiences and recovering from those. And so it's not rocket science. It's doable, and it's out there, and it's being done every day by therapists everywhere. So we have a chance to get on kind of the train of trauma-informed care for our own workforce, and also create the systems that support people through really traumatic events. I mean, even if a mistake isn't made, even if all the care is perfect and it's an unhoped for, unwanted outcome, that could be devastating. And people carry that around with them, and they fill up their backpack with rocks. And their ability to run uphill with a backpack full of rocks, which we're asking them to do every day, goes way down. And so we need to help them take some of those rocks out of the backpack and, unburden themselves.
Yeah. Well, I'm going to share very briefly an experience I had where I actually didn't have time to lose trust, but I would have. So many, many years ago, I had a lump in my breast that I was about 100% sure was breast cancer. And I was pregnant, so it was very, very hard. And I went to see a surgeon that I didn't know, and my obstetrician had reassured me that it was nothing. It was related to the pregnancy, but I knew deeply this isn't bad. And when I saw the surgeon, he did a needle biopsy, and he said, "I think you're going to be fine. This is okay. Please go home and get a good night's sleep." And boy, oh boy, was I thrilled, relieved. I actually went out and bought a baby name book because I thought, okay, everything's going to be okay. And I went home. I had a good night's sleep. And I did have a cold, and so I stayed home from work the next day. And I was at home, and I get a phone call from the surgeon. And he's calling to tell me that I have breast cancer. And I was in shock. And he was incredibly kind and nice. And we talked for a few minutes about what I was going to be doing next. And we hung up. And in about 5 minutes, he called me back. And I thought, oh, dear, is this going to get worse? And he said, I'm calling you back because I have to confess that I lied to you yesterday. I was extremely worried about you, which is why I had this biopsy run through as an emergency. And I know it's someday, at some point, you're going to remember that I told you that everything was going to be okay, and you will never trust me again. And I just kind of sat there and thought, he's absolutely right. I haven't even had time to process all this, but all of a sudden, I adored him. I so loved his honesty, his willing to be vulnerable and share that with me. And to this day, we're still friends. And lo and behold, he was right. I'm still here. But that was such a powerful experience for me to have him admit that he was really lying, which I think is very hard to do. But I just share that because I think that kind of candor and that admission, he will forever be a hero to me.
That is an amazing story, and I'm sorry that you had that experience. It's very actually terrifying.
Well,
to
it
do that.
was terrifying, but I'm here, and I actually had a chronic condition for many years before that, and I immediately said, okay, I know how to deal with this, and I'm not going to listen to any of their horror stories. I make up my own prognosis, and was off to the races. So anyway,
Well, it's incredibly insightful of him to use his vulnerability that way, because that's probably counter to the training that a lot of us got,
yes,
which was to always have the answer and sort of be unemotional about things. And we have to learn we have to back into this new way of being in touch with our feelings a little bit more and actually sharing that in a vulnerable way with the people that we're on the team with.
yeah, oh yeah.
Amazing.
Yeah, I've had other experiences that were sort of similar, but nothing that was that profound. But that kind of honesty and vulnerability, and actually saying, I don't have a clue what's going on, let's try to figure it out together, is so incredibly valuable. So we've got just a few minutes before we address many of the questions in the chat and other questions that came in. But as we begin to wrap up our discussion, can you share a little with us about your experiences with leveraging technology? How do we bring the analysis of patient-specific data to the provider at the right time? And how can we use the new technologies that we now can avail ourselves of to model risk and improve outcomes?
Well, it's a big topic. We could talk about that for an hour, but the short answer is I'm very excited about what technology holds for us. And there's a couple reasons why. One is our ability to know people. If we're willing to engage with the data, our ability to know people as a whole person and what socioeconomic world they live in and what their patterns are, that is taking off. And so we should be able to know ahead of time, before someone visits us, a lot about them and a lot about what they need in their visit. And I think that the challenge is going to be going from a very reactive post, kind of almost, I call it like archaeological approach to our patient's experience with us, to a more proactive listening approach to even preemptively say, well, we know this about you, Susan, and so we've set up your appointment this way, and we think you might want to access our system this way. And, the listening in the moment, listening ahead of time, thinking ahead of time and more upstream of the care encounter, to me is incredibly exciting. I think secondly, patients are going to be much more empowered with their own health data. For example, from their watch, from their phone, from their continuous glucose monitor that they're wearing because they want to know how to control their glucose levels, even if they're not diabetic. And they're finding ways to get healthy and to monitor their own health outside of the traditional healthcare system. So that democratization force is going to be strongly powered by technology. And I think the third thing I'd bring up, AI has such a potential to improve kind of aiding our clinicians in doing their work to make it easier to get to the right answer. Easier to do the clerical work, so they're not tied up documenting, and that they are getting super smart decision support around what could be a hard decision-making process or diagnostic process, where we still have a lot of errors, by the way. Bring that technology, that very powerful technology, to bear to help people at the front line do their best job. I'm really excited about that in the future, but it's on the healthcare organizations to really dig into that and engage. And not run away from it.
Yeah. Well, two other things that I think may be helpful in that universe are open notes, where people can actually read their clinical notes and look at their medication lists, their test results, and everything. And I think the Open Notes team has done excellent research about how that has improved medication adherence, trust, as well as reduced errors. because people identify things in their record that are incorrect that make a difference, that can be quite important. And the other thing I want to mention is the whole international What Matters to You movement that really focuses on understanding what is most critical to a person about their life, what makes them happy, what brings them joy, what helps them support their health, what are the barriers that we can help people address. And the more that we know about those things, the more effective we can be. And that's what we care about. So I think those are both things that I would encourage people to look at. And with What Matters to You, we're all different depending on what our clinical condition is. You know, what matters to me if I have a cold is very different than what I might say matters to me if I have a much more serious diagnosis.
I love it. It's really the development of that idea of person-centered care.
Yeah.
Holistic view.
Yeah. Yeah. Well, I think we are right up against our time to ask some questions. And excuse me, I just need to look at the chat, but I know we got a few questions ahead of time. And one that I'm just going to jump right into because I think it may be, unfortunately, easy to answer, is we got a question about how physicians should be involved in discussing the financial aspects of care or the cost of care. And so, Mike, I don't know if you want to, we had a little chat about this before we started, but I don't know if you want to sort of tackle that one.
Yeah, Susan, it's really important. And I think organizations that lean into this are getting better outcomes. They understand that one of the greatest drivers of a really high quality experience is the financial process. And that goes all the way to transparency. What are we going to know up front that our care is going to cost us? And, you know, disruptors in the space like Amazon Healthcare is going to tell you ahead of time what your care is going to cost before you access it. And so the traditional health systems are actually at risk if we don't get really good at getting transparent quickly around pricing. And I think historically, you know, as a physician, you know, most clinicians have just said, "Oh, it's somebody else's issue." And the result of that abdication of power, though, is fairly sad because it means that our patients might have the greatest experience with us, and we might have a deep bond that we develop with them, and they won't take their antibiotics or take their cholesterol pills because they can't afford them, they can't access them, and they got surprised by a big bill that just overwhelms them. And we have no clue about that. And in my mind, we can't keep operating that way. As physician leaders, we have to dig in and advocate for our patients, that they need to know what care is going to cost, and it has to be affordable, and we have to access, and I think you'll comment on this, access financial service support whenever it might be useful.
Yeah. I mean, I think I can't imagine how a doctor could answer questions about costs because most of us can't even figure out what our insurance plans cover and what we have to pay for, much less a doctor who sees, you know, dozens of people all the time. And so, but I do think that one of the things we've learned is that connecting people with financial counselors, and I would bet that most of the people that are listening to us today don't even know how to get in touch with financial counselors in their own organizations, but it's something you need to learn more about. That is such a powerful resource for our patients, and it absolutely increases their trust, and it is one of the strongest ways that we can actually provide emotional support. I mean, the cost of care is the #1 cause of bankruptcy in this country, and so getting people that kind of help is essential. And I'm gonna reach out to Jessica and see if you want to comment on some of the other questions that we got.
Thank you to you both so much. Yes, when we asked you all to register for this conversation today, you submitted some questions for Mike and Susan here, so I'll read one of them. One of them is, how do you feel patients can play more of a role in their own healthcare given that there's earned mistrust in the system?
It's a great question. Susan, I think you're going to let me try to answer that one first.
Well, I'm going to let you start. Go ahead.
To me, it really means kind of advocating for yourself and setting rules with the people that you're working with about what you need, and not being afraid to make your needs clear. And when you don't understand something, to speak up and to ask hard questions, and expect that we shouldn't be able to ignore a hard question. We shouldn't be able to brush it under the rug or say, oh, that's just the way we do things. We need to be engaging fully in those hard questions about care and about why care is a certain way. So I think a lot of it has to come, or should come down to being empowered to ask the right questions. Now, Susan, I think you're going to have thoughts on how that can happen.
I do. I think that we need to do a lot more in terms of coaching people about how do you get your questions answered and what's actually realistic in the course of a visit. So you can't walk into a 15 or even a 30-minute visit with 50 questions. So you don't just show up at a doctor appointment like you haven't thought about it. You have to write down the things that you really have questions about. You have to prioritize them. And you also have to understand that there's no way that you may be able to cover all of them, but you can come back. And you can get the information in other ways after a visit. But I also think that people are often very discouraged when they do ask a question and they're told, well, we don't have time for that today. There are better ways in terms of communication styles that you can say, that's a very important question, and we'll get to that. But there are a lot of things about that. And I have to share that many years ago, it may have been Deborah Road or one of the really well-known researchers in doctor-patient communication did a study about patients asking doctors questions, and it was involved medical students with preceptors, and they were told that they should tell the patient at the end of the visit, now, do you have any more questions? And they videotaped, and what they found is that they would say, do you have any more questions? But as they were saying that, they were literally shaking their head, no, you better not have any more questions. And I think we still see a lot of that. But I think there are lots of ways that we can help patients feel more comfortable, and we can also share information asynchronously that can be very powerful and effective.
Jessica, I also think that patients will increasingly vote with their dollars and with their business. And as more alternatives come up digitally for the kind of care that they want to access and in a consumer-friendly way, they will access those services and not maybe necessarily interact with their traditional healthcare providers. And we see that already in the kind of sexual health and reproductive health space, and people seeking digital care because it's more discreet and it makes them feel more comfortable and they don't have to look somebody in the face. So that's a real trend that will continue.
Yeah. We're seeing comments in the chat about what not to do. So
I was going to lift some of those up. I think we talked a little bit about this when we were discussing the question of cost. What do you encounter not knowing what something's going to cost? And Adam Scheffler's comment here is some specialists don't want to engage in questions over cost. And I'm guessing why that is, but do you have any reaction to that, Mike?
Well, again, we were trained in a very us-centric way. It's very inward-facing to say, my care is my business, my training is great, and I don't have anything to do with your financial concerns. I'll do my part of it's a very narrow-minded approach, and sadly, it's the way that we were trained. Because the system is so complex and it's almost unknowable sometimes to give an actual dollar amount for people, and it would take so much of our bandwidth as a clinician trying to solve a clinical problem to say, yet it's an incredibly important part of the patient's care. And so realizing that and saying, okay, we're going to take a team approach, and I've got a teammate who's going to help you work through these issues and get you an estimate of your care. We have that capability, and it's on our team. That's a really important distinction to just saying, well, no, that's not my business versus my team's business is all of your concerns, and we will have somebody on the team that can help you.
I think that's actually the most realistic thing we can do, because I think most of our clinicians, you don't have a clue what someone's plan covers, what it doesn't cover, what type of coverage they have, et cetera. So it's really challenging. But I do think that people think that doctors may know and just aren't telling them. And so they actually need to be more transparent about what they do and don't know, but how to get that information from people who can help.
Well, and I think the other thing we could share, Susan, along those lines is we do a lot of great work to reduce cost and to give the lower cost care because it's best practice. And so do we actually take the time to say, we're prescribing this antibiotic? We used to prescribe much more expensive ones, but now we've gotten it down to 3 days of a very cheap antibiotic because that's best for you.
Yeah.
You can trust this care. I think we need to toot our own horn when we actually are involved in that work.
Yeah.
Thank you for that. A little quote from Bill in the chat from Victor Montori, who's at Mayo Clinic and who's done a lot on patient communication here around transforming healthcare from an industrial activity into a human one, which I think you're both shaking your heads at. Backtracking just for a moment, thank you both for sharing the stories you did. I'm sorry for the experience you both went through with your patients and with yourself, Susan. And I'm wondering, since we touched on this issue of trauma-informed care, do you have any resources for folks who are looking to learn more, or places where you first learned about supporting people with trauma-informed care?
Wow. I actually know that in our system, I'm at Mass General Brigham, and McLean Hospital has a very gifted psychiatrist who runs a whole program. It's an educational program. She sees patients, but it's a training program for clinicians and staff about trauma-informed care. And I also know I had an experience several years ago as part of the CAPS consortium work. We often do webinars that feature the top performing groups in whatever survey that we might be thinking about or focusing on. And we had a webinar about Medicaid health plans. And there was a Medicaid health plan, and it was in Oregon, and their patient experience scores were over the top. And what they did is they trained all their member service people in trauma-informed care techniques so that when their members, who all lived challenging lives, would call up, they would get a lot of support, and they understood how to interact with people that were really afraid and really stressed, and boy, did it show up in their data.
That's fantastic.
But I think there are lots of programs available, both virtual and in person, that are excellent.
And I would just add that if you don't know, in your organization, talk to whoever's leading your social work, because they will know. This is it's a main arm of therapy now, big field, and everyone will know about it, and they'll know how to take some steps there.
Thank you both for this. And I'm wondering, given we started the conversation with some of the cuts that are being made to people who are in nominal positions of authority around patient experience within institutions, and then some of the critical, why it's critical that folks focus on this. So given that it's at risk and where we are now, do you feel more optimistic or pessimistic about the future of patient-centered care?
I think, for the technology reasons I mentioned, for the idea of trauma-informed care that we're talking about, these are really great advances in how we are going to be and are great advances in how we relate to each other. And I just think we're getting smarter about interpersonal issues. We're getting smarter about training leaders to be vulnerable and human-centered. We're actually... One area where we really haven't dug in is around the subconscious motive drivers of trust, which my friend and colleague Chris Malone has put together a framework that's based on warmth and competence. But that's well known in the social sciences. We haven't really applied it to healthcare yet. But we have a lot of new things coming up that we know about human psychology that we can apply to healthcare to build trust and to really improve the way we provide care. Because ultimately, I will say, The equation that people like to say about any process, and this gets back to the industrialization comment, people, process, technology, three main components. I would submit to you that the hardest part of that is the people. And most of my job as a leader of complex systems and high-performing teams has been psychology. How do we get the teams to feel good about giving their all every day? How do we make sure that when they're hurting, that they get taken care of? And how do we know that they have the knowledge and resources to perform at a very high level to deliver the outcomes that we know they can deliver? That's psychology, most of it. So as we deepen our knowledge about from the social sciences and in psychology and in therapy, we need to apply those to how we provide care writ large.
Well, I'm a hopeaholic, and so I think that we have to be relentless in educating everyone in healthcare, and especially all the new and up-and-coming leaders, that person-centered care is absolutely at the core of what we do. It is not just the fancy wallpaper. And that just annoys people when you try to look like you're a Four Seasons, but once you get past the lobby, it's awful. People they're not stupid, and that really infuriates them. And so the more that we can educate our leaders that this is core to the clinical outcomes and the employee experience that everyone is desperately trying to enhance, I think we'll be fine.
Thank you.
But it's relentless.
To borrow a phrase from you, Mike, I can tell with you both that the audio matches the video in terms of what you both taught us today and how you show up in your work lives. And so thank you so much for that. Thank you all for joining us today. And thank you, Mike and Susan, for this meaningful conversation.